Good evening, everyone. I'm Dr. Kaladhar from Yashoda Hospitals, Malakpet. So, welcome to our Tuesday Masterclass webinars from the Department of Critical Care Medicine, Yashoda Hospitals, in association with the Hyderabad IDCCM chapter. So, with this, we bring forth academic sessions every Tuesday and every alternate day, the masterclass where senior and seasoned clinicians and critical care examiners and teachers will be there, along with the students presenting with the good academics, which is very much helpful to the DrNB, DM, IDCCM. Most of them, they log in almost near to 150, 200 people, and along with that, they later watch these, and especially most of the people, they told feedback that these sessions are very helpful, especially during their exams. So we're very, very happy with their feedback. And for today's topic, I welcome our senior seasoned examiners to senior seasoned examiners, Dr. Sunil Karanth, sir. Very privileged to have you on our platform, sir. Previously, you were there. So thank you. And he's the head of the department, senior consultant, critical care medicine from Manipal Hospitals, Bangalore. So we welcome you on board, sir. So I welcome Dr. Vaishali Solao, madam. So she's a senior consultant and head of the department from Fortis Hospitals, Mumbai. So, today's topic of discussion is acute liver failure. To present this, we have two students, Dr. Prithwiraj Saha and Dr. Arnab Banerjee. Both are DrNB critical care medicine students from Fortis Escort Hospitals, New Delhi. So, yeah, Dr. Prithvi, I think your colleague Dr. Arnab is also there, probably, with you only, no? So you can start your session now. So. Venkat sir also joined. Yeah. Good evening, sir.
Good evening. Thank you both of you for actually accepting our invitation, and over to you, Sunil sir.
Thank you, Dr. Venkat. Hello, Dr. Vaishali. It's been a while.
Hi.
Sir, shall we start?
Yes.
Yes, please. Please start.
Good evening, teachers. Today we are going to present a case which came to our ER. A 28-year-old male presented in the ER with a complaint of fever with headache for last 7 days, nausea and vomiting for 7 days, and along with the abdominal discomfort for 6 days. He also complained of generalized weakness, decreased intake, and yellowish discoloration of eye for last 4 to 5 days, and which brings him to the ER is the increased sleepiness since the last 24 hours. Next slide. The patient was all right 7 days before when he developed low-grade temperature around 100 degrees Fahrenheit, which is associated with nausea, vomiting, and headache. The fever was intermittent in nature and was relieved by paracetamol taken by the patient in the initial days at a dose of 650 mg QID or 4 times a day. Subsequently, the patient developed body ache and a right upper quadrant discomfort and progressively developed yellowish discoloration of eyes and decreased appetite. Now he came with a complaint of increased sleepiness for last 24 hours. He had a history of attending his friend's wedding ceremony outside Delhi 14 days back. He had no history of cough, burning micturition, loose stool, hematemesis melena, or acute loss of weight, or no insect bite or any intake of herbal medication or some unknown medication as per the history given by the patient. Not patient and also the relatives, because the patient was little bit drowsy, so his relatives has given this history. Next. There is no similar complaint of the patient in the past, no known comorbidities as the patient is quite young, 28 years of age, no history of surgery or hospitalization in the past, and no history of blood transfusion. taking to the personal history and the family history, there is no such family history of jaundice in his family or similar episodes in his family. Bowel and bladder is normal. Last bowel movement takes place 2 times the day before when he came to the ER, which is normal, yellow in color. Urine output was adequate till then as per the family and is yellow in color. Diet, he takes mixed veg and non-veg diet. History of alcohol, he takes 2 to 3 drinks per week. He is married and have no such family history.
Vaishali, just want to interrupt, Prithvi.
Yes.
So, Dr. Arnab is also there with you, no?
Sir, actually, he is coming from another unit of our hospital. He is on road, actually. He is coming within 2-3 minutes.
Not a problem. So, Vaishali madam, you can interrupt anytime in between presentation and ask question.
Yeah, let him finish the history fully, I thought, then.
Yeah,
Okay.
this alcohol intake needs further qualification. How much, what concentration of alcohol, and how long?
I think very importantly, was there a binge,
Yeah.
particularly important history, which is not been particularly told. Yeah.
Yes,
So
sir.
it would need a further teasing out a little bit, whether it's just 9% alcohol or whether he's taking a 40% alcohol. And that too, when you say 2 to 3 drinks, you have to actually measure in ml and duration also. How long?
Okay.
And there would be also important to see if he has any drug addictions. That also is an important history when you start talking about jaundice.
On general examination,
can you just summarize the history in 2 lines and give a differential for what you have given so far?
sir, from the history, what we have got in this patient, that the patient presented with acute febrile illness with jaundice and with generalized weakness and increased sleepiness, which is correlating with his CNS. So, sir, for differential for acute febrile illness with jaundice, we can have firstly the hepatotropic viruses, which are hepatitis A, B, C, and E, and also secondarily hepatotropic viruses uncommon, which are like varicella zoster, herpes simplex, Epstein-Barr viruses, and also the tropical fevers which are important in our country are the malaria, dengue, leptospira, or scrap typhus, the 4 which we'll mainly look for. And sir, for fever with jaundice, there may be some also intra-abdominal pathology like acute cholangitis, liver abscess, or in some cases of acute pancreatitis, if it is associated with gallstone like this.
So the hepatotropic viruses which you mentioned, can you count them again?
Sir, ma'am, hepatitis A, B, C, D, E. Matlab A, B, C, and E. D mainly comes with B. So
this is acute. It is of 7 days duration.
Yes, ma'am.
For
this, hepatitis A and E are the main concern.
Right. Yeah, exactly. Hepatitis C never presents as acute.
Okay,
never. So C will not be in consideration for an acute. B, yes, sometimes reactivation can present acutely, but A and E remain on top.
Okay.
And then, yes, you can consider B also.
So, among the differentials, you would say this is some sort of hepatitis, and you gave all the different differentials for that, isn't it? Any other possibility you can think of? Somebody coming with fever, jaundice, and a bit of alteration in the sensorium, other than, because whatever differentials you gave was largely for hepatitis, infective, non-infective, etc. Any other differentials you can think of? It
can also cause, any sepsis, septic shock, or any meningitis also. It can also present with fever in late stage when it's have a systemic infection. It can present also in septic shock. It can also present at fever with jaundice.
Hmm. Any other rarer causes you can think of? Okay, agreed.
Can you think of
Hepatitis.
non-infective
sepsis,
causes?
Yeah, non-infective causes.
Non-infective causes, can you think of?
You can present
Carcinoma
with a short
can
history of all these findings that you said.
so non-infective like drug poisoning. Some poisons also can, but fever.
Hmm. Can you when you say drugs, can you elaborate on drug? Though there was no drug history, of course. What are the drugs you think? So see, when in the history, I mean, you should be able to, you have got the history well, but it is very important to give a very broad differential in the history, particularly in the exam. If they stop you at the end of history, because you can't, now you probably know the case, you are saying hepatitis, this, that. But I agree, first diagnosis, what you said so far is fine. But you should have a broader spectrum of or a grid that you should be able to say that other differentials. So as Madam asked you, any other non-infective causes? Okay, you said drugs. Anything else can present like this? Maybe rarer causes, but is it a possibility?
Autoimmune hepatitis or
Okay.
Yeah.
Good.
Anything to do with blood coagulation, which can present like this?
but cherry.
Hmm? Yes.
Yes.
Hot cherry, yes. BCS. Jaundice encephalopathy. Anything else? Was this in summer or something? What season did he present in? That's a clue. Does that give you a clue? Of course, it won't be 7 days duration, but even a heat stroke can present like this. The duration is too long. It is 7 days. A shorter duration would have been more appropriate. But yes, even a heat stroke can present like this.
So you did mention autoimmune disorders. I think just could be autoimmune hepatitis or any other other sort of systemic autoimmune disorders are possible, connective tissue. Malignancies with the primary being in the liver or some other disseminated malignancy with the secondaries in the brain is a possibility. So have a broad net framework when you end the history, infective, non-infective, or you can say inflammatory, non-inflammatory, malignant, vascular, traumatic. That structure, you have it in your mind. And then based on that, you can start putting the jigsaw together. Okay?
Okay.
Right.
The other rarer cause will be something called as macrophage activation syndrome with liver infiltration, which can also present like this: fever, jaundice, encephalopathy. It can lead to liver failure, macrophage activation. So
And
yes, you should.
hemolytic anemias
HLA.
precipitated by some infection or just an acute hemolytic process is a possibility. Okay.
So for exam purpose, I agree completely with Sunil that you must have a differential for non-infective causes also. They may not be on the top of the list, but yes, the list should be completed with non-infective causes also.
Okay, ma'am. Sure. Ma'am.
Yeah. All right. We'll
In
go
the,
ahead. Yeah, Dr. Vaishali will proceed.
Yes, go ahead.
Yes, please proceed.
in the general examination, the patient was drowsy but arousable, but little bit sleepy. The GCS was E3V5M6, moderately built but looked grossly dehydrated. Pallor clubbing cyanosis was absent, and the icterus was present on the sclera and the bottom of the tongue. The pulse rate was 112 per minute, and the BP was 102/59 mmHg as measured in the NIBP in the monitor. The SpO2 was 94% on nasal prong 2 liter per minute. The temperature was 99.8 degree Fahrenheit. And the RBS sugar measured on arrival at ER was 88 mg per DL. On going to the systemic examination, the gastrointestinal system, on inspection, there was distended umbilicus, which is inverted, no localized swelling, discoloration, or pulsation, no dilated or engorged superficial veins. On palpation, the abdomen is little distended, soft, no organomegaly, and the mild tenderness in the right hypochondrium. On percussion, the There is tympanic node and no evidence of fluid in the abdomen. On auscultation, the bowel sound is present. Central nervous system examination, GCS, as we already described, E3, V5, and M6. The higher mental status were intact and the patient was drowsy with increased sleepiness. All 4 limbs have a power of 5/5, so there was no focal neurological deficit. The bilateral plantar was equivocal. The flapping tremors were present when asked to the patient to expellate, and the pupil was bilaterally equal and reactive. Cardiovascular system shows no abnormality, where the respiratory system, which was described in this heading wrongly, is the right-sided, shows basal crepitation, and there was no detectable abnormality in other systems. While the imaging, this was...
Hold it,
yeah,
hold it, hold it.
Again, hold it. Yeah. From this examination, you will have to make a conclusion as to what your examination is telling you. Make a succinct conclusion. What is it added to the history? What is your conclusion on this general and systemic examination?
Complete clinical diagnosis, in other words.
I remember added to the history with fever and jaundice from the examination. One thing we got that the patient is grossly dehydrated,
Okay.
and the patient is hypotensive with tachycardia. That is, the patient is having...
Sorry, what did you mention the blood pressure to be?
102/56.
And why would you qualify this as hypotensive? What is the MAP? The MAP has to be more than 65 over here. Would you call this shock?
Ma'am, shock is not always on base of BP. So
Agreed completely. So why do you say he's hypotensive?
Why did you add the word hypotensive?
Hypotension. How do you define hypotension?
the MAP below 65 or SBP less than 90.
So either of these two is not fulfilled over here. So why do you say he's hypotensive? I agree to the dehydrated part, but from what numbers you have given, it doesn't seem like he's hypotensive, right?
Yes.
Yeah. Anything else from the examination that you conclude?
And ma'am, there is a generalized weakness with decreased sensorium of the patient. There is no focal neurological deficit, and there is mild tenderness in the right hypochondrium. So maybe some that the pathology is like...
Make an impression out of it. Make an impression. Now you are
Exactly.
repeating the positive findings. We got the positive finding. Or okay, to be more, as Dr. Vaishali said, to be succinct, you can have a 2-line summary of all put together, and end of it we want a complete diagnosis based on this impression. Not, there's no point in repeating the positive findings.
Okay.
So he's dehydrated, you said. Is he hypoxic?
Yes, ma'am. Yeah, is requiring oxygen of nasal prom of 2 liters per minute.
Okay. Third, what is the more significant then? He's jaundiced.
Jaundice, yes.
Yeah. So he's dehydrated, hypoxic, jaundiced. What else? Encephalopathic,
Encephalopathy.
isn't he?
You can even qualify the grade of encephalopathy here, isn't it?
Yes, sir. Yeah, grade 2.
Yeah, then.
Yes. So you have to qualify the grade of So how do you, on what score is this encephalopathy classified? On the background of hepatitis? What is that scale called as?
West Haven
Yeah.
grading.
Yeah, West Haven. So this will be West Haven grade 2.
Yes.
Yeah. Okay.
So, sir, on the basis of this history and examination, we can conclude that the patient is having an acute febrile illness with hepatic and central nervous system involvement, with systemic manifestation which yet to be concluded from the investigation.
Yeah, can't you be a little more precise? I mean, that was more like the summary, I would say, of the positive findings. So what are the differentials you would consider, or what is the diagnosis you would come to? Acute febrile illness with jaundice, and on examination, you said there was evidence of encephalopathy.
Yes, sir.
So what would you conclude at the end of it? So my differentials would be
What differentials would be, sir? We same as acute viral hepatitis is the first differential. Second are the
Is that all? Acute viral hepatitis, do you end it at that? Full diagnosis.
So when the encephalopathy comes,
Pathy comes, exactly.
what is it called as? When encephalopathy comes,
Sir, it is acute liver failure. But
So-
that means, ma'am, INR we also should.
No, not necessarily. Jaundice is there, encephalopathy is there. How do you define acute liver failure? Can you tell me the definition?
The acute liver failure is defined on the basis of 3 points. First is the insult of the liver, which is manifested as jaundice, superimposed by, along with deficiency in the synthesis that is manifested by INR greater than 1.5 and any grade of encephalopathy, and the duration of onset of encephalopathy from the jaundice is defined in different definition, but taken together is considered up to 26 weeks in a patient with no chronic liver diseases.
that's right.
So,
How do you classify further this
Yeah.
acute liver failure in terms of the duration of jaundice to encephalopathy?
Ma'am, within 1 week up to 7 days is hyperacute, 7 to 28 days is acute, and 5 to 12 weeks is subacute.
it
So,
depends
can
on which classification you're using as well. Isn't
O
it?
grade D.
Already, yeah, this is
Yes.
over.
Okay.
So
Do you
your
have any other classification?
Ma'am, sir, there are Japanese classification and
Mhm.
other one to classification.
Mojidas, no? Mojidas and Bernals,
Mojidas.
okay? Yeah, I mean, one of them, that's fine, but just be aware that there are a couple of other classifications as well. Yeah.
So if this is jaundice with encephalopathy, what category does it fall into on the O grade scale?
Ma'am, as the onset of this encephalopathy from the jaundice is within 7 days, it's coming to the hyperacute liver failure.
Okay.
Okay, go on.
Sir, the imaging done on the bedside, on the
So
bed.
can I interrupt you there?
Yes,
At
ma'am.
this stage, don't you have a blood gas on him? He was
Yes.
tachypneic, he was hypoxic.
Yes, ma'am. Next slide, we have mentioned it. Actually, we have to mention this imaging on the next slide. As the space were limited, so better we discuss the next slide. Please, next slide, please.
No, 1 second. No, this is kind of an exam, so it is fine if you don't have space in the slide and all is different. But when you talk about general examination in an ICU patient, it is important to add, or for that matter, in the end of examination, we would expect an ABG also to be put up or to be told, okay? So because that will further help you to qualify your diagnosis. So if I could just take you back, always when you present the history, pause for a second or two. Now, some examiners may choose to say that, okay, you give me the differential, some may say proceed. So just pause, or it may not be even a bad idea to just put a 2-line summary and say, these are my differentials. And further to that, I will do my examination. These are my examination findings. End of examination findings. Again, the differentials, if it is the same, it is fine. And during the presentation of the examination findings, you would also add to say that because in ICU, the point of care tests or the bedside tests become a part of the examination spectrum. So you would say that finally at the end of examination, these are the things that I found. And my ABG said that there was metabolic acidosis, yes, no, whatever it is. And then you say that all put together, this is my diagnosis. And okay. So it may not, it may not go in the pattern that I'm telling you, but pause at the end of history for a brief 2 seconds. Don't keep on rattling it out because, some of them may want you to give a brief summary. Some of them may not want you to. And also it may not be necessary to go into such heavy details in history, because at the end of the day, we are not training you to be a internal medicine doctor. You are training to be a critical care physician. So your history should be brief with relevant negative features. As in the history, I think you didn't talk about drug history, as Madam told you, or there was no history of alcohol, binge. These are all important things which are, so few things you did mention, I'm not denying that. But these subtle things, because then we know that as a candidate or as a critical care physician, what is your thought process? At the end of the day, it is not about finding what you know as a postgraduate medical student is not what we want, but we want to know what is your thought process, which starts from the first line of the history itself. Okay, so you should lead the examiner towards the diagnosis and give the differentials and move on to say that this is my first diagnosis for this reason. Second, third, fourth possibilities are these, but they are not considered for this reason, and proceed. All right. Okay.
So bedside focus done, and the IVC collapsibility.
Can you go on to the ABG first? I think the ABG is important. It gives you some clue there.
Yeah, I think it is in this slide on Dr.
Yes, ma'am.
Yeah, so there is acidosis.
Yes, ma'am. There is acidosis.
There is hypoxia, and there is also hyperlactatemia.
Yes, ma'am.
Can you qualify the metabolic acidosis?
I don't get what is.
There's not
24/17 is bicarb, I think.
Where is the PCO2 here?
Sir, 24.
24.
Okay.
Last line.
Right. So yes, as Sunil asked you something. Does he have acidosis?
Yes, ma'am. The patient is having acidosis as the pH is 7.32.
No, that's fine. We don't need you to tell why it is acidosis. We want you to tell, see, metabolic acidosis. Acidosis is okay for a first year graduate or for somebody who is not doing ICU. But for you, I would be expecting you to say, on my examination or on my interpretation of the ABG, I find this. What metabolic acidosis? High anion gap, delta gap there, not there, or only single acidosis. That is what we would want to try. And is the compensation appropriate or not?
Yes, sir. Sir, this is a high anion gap metabolic acidosis, though the values of this.
With, we are not worried about though. With what? I am not convinced that it is only metabolic high anion gap metabolic acidosis.
And or with respiratory alkalosis also.
Yes,
sir, there is
very important. See, the moment you add the respiratory alkalosis component, it completely changes the spectrum of what we are talking. Okay, it further corroborates your evidence of either the fact that there is hyperventilation secondary to a central involvement, or the fact that there is something else happening. Of course, hypoxia is also there. So this is very important. That is the interpretation we want. That's why I keep telling you, impression is what I want. I don't want heart rate, pulse, blood pressure, because that will be the nurse's job in the ICU. But I want you to interpret those signs and give it to us, okay? Because you are a national board candidate or a DM candidate, and you are going to be the flag bearers of critical care for the future. So what we expect, you will be presenting to the examiner as if you are going to hand over to a critical care consultant colleague. All right? Okay? Yeah, go on.
So, sir, there is. So, will I repeat a bit or?
No, don't.
For the focus. So, sir, the bedside EOSG or the focus which done screening, the IVC collapsibility index was greater than 40. The heart, the chambers were not dilated. Contractility was fine on screening.
So what will you interpret out of this IVC collapsibility index of more than 40 in a person who is not intubated? I will say it is collapsing because he's hyperventilating.
Sir, in a spontaneous breathing patient, sir, IVC collapsibility index greater than 40 is indicating that
what
the
is
patient...
newer evidence say?
Sir?
What is the new evidence in favor of this? Is it useful or not useful?
What what is indirectly, what is the sensitivity, specificity, or the
Yeah,
area under the
sensitivity
curve
of
for IVC collapsibility? What's the
collapsibility.
AUC? Even if you know the AUC, it's good enough. So the reliability of this finding, what's the area under the curve for IVC collapsibility?
Sorry.
Because you have not given me the IVC diameter. Probably that would have been a more explanatory thing for me. I know what you're trying to convey to me, but I would go more by the kissing sign, maybe the IVC diameter, but collapsibility for somebody who is hyperventilating, I would not take it as a significant finding.
And the AUC is 0.69.
Yeah.
You can still be wrong 0.31%, 31% of the time, based on, as he said, if there's hyperventilation, which is causing excessive interpretation of the collapsibility. So you should know the accuracy of every parameter which you're using, the reliability, because you're giving this is the exam. So you must know what is the downside of using one particular test, and what is the accuracy of that test.
Okay, proceed.
So in lungs, sir, there is right-sided mild effusion and the A profile in the lung USG, and there was no free fluid in the abdomen as examined by us in the ER. The IV fluid, the management which started
So your
with
focus conclusion is just one word:
patient is dehydrated.
volume response
Dehydrated
is what I would call.
very,
Yeah.
Volume
yeah,
depleted.
it's a vague term.
Volume
Can you be more? Do you check for dehydration with the? Yeah, you tell. Sorry, somebody was adding something. Tell me, what is it?
volume depleted.
Yeah, intravascularly volume depleted. Okay, that would be a better term. Yeah.
Sir,
Go on, go on.
sir,
Can you just
the
go back one slide, because there was something else in the previous slide which we missed. Yeah, the imaging. I think we finished this, Dr. Vaishali. I think we'll finish this ultrasound finding and move on now. Just for completion. Yeah.
imaging, so the imaging which was done by the radiologist is the USG whole abdomen done, which reveals grade 1 fatty change of liver with maintained echo texture. There was no intrahepatic biliary radical dilatation. The CBD was normal. CBD was not dilated, and there was no splenomegaly, and the portal vein was also normal. The portal vein flow and the diameters were also normal.
Okay.
The pancreas was not visualized well, but appears to be normal. In kidneys, as CMD, corticomedullary differentiation is maintained, and there is increased cortical echogenicity.
And fine, just read the positive finding there.
Answer, CT head done was within normal limit. The report gave there is mild features of cerebral edema, but there was no hemorrhage or any ischemia or any
That's a contradicting
That's
CT
a very
report.
contradicting statement.
Contradicting CT. You
Within
can't say within
normal
normal
limit.
limits and then say cerebral edema. Yeah.
Actually, this within normal limit term was written by me, sir.
Yeah, I know. I'm
So
not
that
telling
is,
your radiologist.
that is even a bigger crime, I would say, if you have written it.
Yeah, I'm sure the radiologist has not given it as within normal limits. Yeah, okay, right.
No, but
So
why
see,
was
be
CT brain
careful
done?
with. Sorry, yeah, go on.
Would you, in this patient who has presented with fever, jaundice, and altered sensorium, what made you do a CT brain plane, CT head?
Ma'am, to rule out to rule out the other causes of altered sensorium, to rule out any evidence of stroke or any.
So is your neurological examination pointing towards stroke?
No, ma'am, but any.
What was your differential diagnosis on history and examination? Can we revisit the differential diagnosis? What was the first topmost diagnosis? Acute liver failure.
Yes.
Right? Due to probably tropical virus, hepatic virus, or some other tropical illnesses. Or yes, some other causes which are non-infective. Right? So our topmost causes still remain infective etiology leading to jaundice and encephalopathy, that is liver failure. Now, I just want to ask, will this what made you do? There was no focal deficit that you established on the CNS examination, right?
Yes, ma'am.
Right. So what was it that you're looking for in the CT head? And will you do a CT head for every patient who presents with jaundice, fever, and encephalopathy?
So I am not too sure whether you are part of this decision in making CT scan, but I'm very sure the person who has asked for a CT scan was not looking for a stroke.
So what will be your thought process if you want to ask for a CT brain in this person? So there has to be some pre-test probability. You should already know what I want to look for in that test when I'm ordering that test, right?
Any cerebral edema is
Okay.
present or not?
Okay. Yes.
Anything else?
On in CT, ma'am.
What is the definition of acute liver failure? You told there were 3 components.
Yes,
So would
sir.
you be worried of something else happening with one of the components of the liver failure?
Sir, matlab, ye bleeding in the brain due to the increased INR. But
Yeah.
sir, actually from the history, we have no focal neurological deficit. That's
That
why.
is okay. SH can happen. You need not have. I mean, you have to rule out that also as a possibility, no? Rather than saying stroke, I think it would have been being a bit more precise. The cerebral edema is taken, agreed. That's the first thing. But certainly you would want to rule out a bleed of sorts. Yeah, go on. So see, one thing be aware in the exam is that don't throw words around very lavishly or very vaguely. Be a little precise. That's why after the end of the history taking, examination, whatever, spend 2 minutes to formulate your thought that this is what I'm going to talk at the end of history. This is the differential. This is what I'm going to do at the end of clinical examination. People might have done 100 different things in the hospital where you go for various reasons, but you should understand why they have done certain things or not done certain things. Okay? You got my point, no?
Yes, sir.
Yeah, okay, go on.
The IV fluid started and we have given 1000 ml of bolus of Cabilite or balanced salt solution, followed by the Cabilite going on at the 100 ml per hour we have started. Empirical antibiotics were started and the vasopressors were started on arrival to the ICU.
So can I ask you there, why was the vasopressor started? And because he had hypertension?
Yes, ma'am.
You haven't qualified that.
But when on arrival to the ICU, the patient had hypotension on arrival.
Despite
So
your
we have-
fluid resuscitation.
Yes, ma'am.
Despite your fluid resuscitation, there was
1000 ml bolus. We have given her. In spite of giving this fluid, the patient was having hypotension. That's why vasopressor initially was started in the low dose.
What vasopressor was started? So again, intensive care students should not mention vasopressor started. You have to be more precise over here. What dose was started, and you would have to be. Vasopressor is a broad term. What did you start? What is your first choice?
Noradrenaline injection, noradrenaline.
And you should mention the dose also, whether it's 0.1 micrograms or 0.2, because it gives you the severity. It gives you an idea of the severity of the shock, right? Okay. What do you think is happening here? Why is the patient requiring vasopressor? Despite fluid resuscitation, there is hypotension.
So, ma'am, there is systemic inflammation leading to there is generalized systemic vasodilatation, which is
causing... There is vasodilatation. That's all. Right. Okay.
Infusion in acetylcysteine were also started.
Can I ask you to justify your empiric antibiotics, and which antibiotics did you start? With what in mind? So what are you trying to treat by that antibiotic?
Ma'am, we are trying to treat mainly some infection related to the hepatobiliary system. And as the patient is already having jaundice or also generalized fever, some infection, some sepsis we are trying to treating. So
you're trying to treat a bacterial sepsis.
Obviously. Ma'am, it may be a bacterial sepsis causing liver derangement, or maybe a viral also, which can has a secondary bacterial infection in this patient. But it may be definitive, maybe prophylactic. At this stage, we don't have any lab values, so we.
No, again, as Sunil said earlier, don't say words like it may be therapeutic,
Prophylaxis.
maybe prophylactic. There is no role of prophylactic
No role of
antibiotic
prophylaxis,
here,
exactly.
right? So be careful about the words that you choose. Do you think that there is some evidence of bacterial infection from the case you have presented so far? I think there is, but can you qualify it? Where is the bacterial infection, if at all there is one?
So in the lung, ma'am.
Exactly. You mentioned right side basis have crepes, he's hypoxic, he's requiring oxygen. So it is possible that he has some microaspiration and he's already had aspiration pneumonitis probably. Right? So yes, that qualifies your statement that yes, I would like to give antibiotics considering there is a possibility of aspiration pneumonitis.
So
Okay.
we are not debating the point that antibiotics needed or not. The question is what is the possible source of
Thought
infection?
process, exactly.
Okay.
You're not treating the liver by giving this antibiotics, isn't it? Your
You can
differential
even
is
say
viral.
that there is a urine infection maybe, or there could be a gut translocation. All this is possible, but definite evidence, lung is the most likely source in this case. And we are not denying you should not give antibiotics, because till you get more data, we understand. But just try to justify the thing in an appropriate manner. Because if you say prophylaxis, there is no role for prophylaxis.
Exactly. You can't say prophylaxis in somebody who's already in shock and going on noradrenaline. Okay, go ahead.
And ma'am, the urine output while arriving in the ICU was 40 to 50 ml per hour, and the central line and the art line was secured in the patient. These are the investigation which came to us on the day 1 of ICU admission. The TLC, the hemoglobin is 11.2. What's the deranged? The TLC is within the normal range, 7,200. The BUN, creatinine, sodium, potassium, the BUN is 40 and the creatinine is 1.3. Total bilirubin is 8.6, INR being 2.06. SGOT, PT are in the range of 2000, and the hepatitis A virus IgM is positive, and ammonia is 102 micromole per liter. And pH we have ABG we have already discussed.
Don't worry about ABG, we already discussed. Can you interpret these lab reports for us? First the biochemical part, then we'll come to the microbiological part of it.
From this lab reports, we can conclude that there is an acute liver insult with coagulopathy and transaminitis, which is in the range of 2000.
So do you call it transaminitis if it is 2000? What is the definition of transaminitis? What is the definition of hepatitis?
So this is how you will get into more trouble, right? Because you're using, this is clearly hepatitis, mostly because of you have a positive IgM.
Hepatitis IgM, yeah.
So you have shown a positive IgM also there. So this is clearly hepatitis because of hepatitis A virus. Is there something else metabolically from your biochemistry, what you have presented? Metabolically, anything significant?
Ammonia is high.
Okay. Any other comments about any other organ systems you can make?
Sir, there is increased BUN and the
interpret the reports for me.
Sir, the baseline creatinine is.
What is the KDICO classification of AKI? Can you tell me? I know you have prepared for hepatitis.
Sir, for the AKI, the KDICO classification is defined as the increase in serum creatinine of 0.3 mg per DL within 48 hours or
Mhm.
1.5 times the baseline creatinine last known.
Okay. So could we call this as AKI here?
So we have
We
to
don't know the
the
baseline. Yeah.
baseline creatinine.
All right. Yeah. But what is the bun to creat ratio? That will definitely give you a clue.
So it's greater than 2.
Greater than?
20, sir, 20.
So what does it suggest?
So
Does it
pre-renal,
add any value to you? Yes.
pre-renal. Okay.
Yes. So it corroborates your dehydration story, which you were telling us, isn't it? Yeah. And regarding the SGPT, SGOT, do you have any comments to make other than the fact that there is hepatitis? Is there
Sir,
any significance of looking at the SGOT to PT ratio, or it's
Sir, here SGPT is higher. Generally, if in all liver injury, SGPT or ALT remains higher. In the alcoholic, it reverse. SGOT and SGPT ratio becomes greater than 2:1.
any other condition SGOT is greater than PT? Alcohol is 1, alcoholic hepatitis is 1. Anything else?
So alcoholic hepatitis will not have this range of enzymes.
Yeah.
2,900. So in this range, if the OT is more than PT, what is your first differential diagnosis? When the enzymes are in thousands. OT more than PT. PT more than OT, you told us, hepatotropic
Yes.
viruses. But OT more than PT?
PT?
Sometimes OT can be 5,000 or 10,000 also. Ischemic hepatitis.
Okay. Ischemic and dengue, these are two possibilities where OT will be higher than PT. In fact, that is also a clue for you to say what is the likely etiology of the hepatic dysfunction. Okay. All right.
Okay.
Let's move on.
So you have started N-acetylcysteine, is it?
Yes,
Yeah.
sir.
Right. Now, in what doses and what is the evidence for N-acetylcysteine in non-paracetamol acute liver failure?
In non-paracetamol acute liver failure, the evidence of starting NAC is not, there is no clear-cut benefit of starting NAC in non-acetyl induced liver failure. But as per our institution protocol, we have done that like same as the acetaminophen liver failure as
So
150.
let me interrupt you there. There is evidence for NAC even in non-paracetamol etiology, and there is a study by Will Lee from the US, which has justified using NAC even in non-paracetamol etiology.
Yeah.
So yes, there is evidence. So I mean, if your institution has that protocol, there must be, because there is an evidence, isn't it?
Okay.
Otherwise, then you are saying that you are practicing non-evidence based.
No, man, there is no clear-cut mortality.
There is evidence.
There is.
There is. Please look into a Will Lee study for NAC in non-paracetamol etiology.
Non-paracetamol etiology.
Okay.
Yeah.
Thank you.
And it has also given the different etiologies where it has been used as well.
Okay. But be careful when you say that there is no evidence, but in our institute we have this protocol. This is again very contradictory statement, and it's not. You're going to get in trouble like that.
Especially if you go to the exam to some other center, you won't be doing yourself favors by saying such things. Yeah. Go on, please.
Sir, so we have finished this. Anything?
No, no more slides. You're done. Okay.
No.
Okay, so give us the final diagnosis after all this, putting everything together.
Sir, the final diagnosis after day 1 is the acute liver failure due to hepatitis A.
Do you want to qualify it further? Is it acute or
hyperacute?
Yeah. Okay. Then.
And
Due to hepatitis
A infection.
Mm.
So in day 2, the sensorium of the patient dipped further and the HE grade was 2 to 3. The urine output also dropped even after in fluid resuscitation to 30 to 35 ml per hour. The vasopressor was escalated. Here we should have mentioned the name of the vasopressor, escalated to keep
And the dose also, dose. Never forget to mention dose. As an intensivist, dose is extremely important. And that too in micrograms per kg per minute, not ml per hour. Right? Because every institution will have a different way of diluting those vasopressors.
Vasopressor escalated to keep the MAP 65 mm of Hg. The metabolic acidosis also worsened. Here the ABG is on the right hand side, which also have the same, though the lactate has come down little bit, but the pH is still 7.30 with Vicar 15 and the base excess -7 and the PCO2 is 24. So we still have metabolic acidosis with respiratory alkalosis. The patient is tachypnic. A chest X-ray done shows right-sided basal zone haziness. There is increased BAN and creatinine on the day 2, and the increased TLC also from the day 1, and the INR has also increased to 4.6. The bilirubin and the transaminase level are also on the rising trend on the day 2 of investigation. The sugar or the RBS, the blood glucose done on admission and henceforward was persistently below 70 mg/dl and was on the lower end. So we started on 25D infusion. The patient passed motion 3 times after enema and laxative on the day 1. The culture reported are sterile up to 24 hours.
Keep going.
Next slide, please. On day 3, the sensorium of the patient dipped further. The HE now grade 2, 3 to 4, and the patient GCS was E2, V2, M5. So the patient was intubated in view of poor GCS and the worsening acidosis. The metabolic acidosis worsened. This arrow has come down, and the vasopressor again escalated, and the patient was on double vasopressor.
What was your second inotrope vasopressor which you added?
Vasopressins.
Okay. Yeah.
Patient urine output is still around lower side of 20 to 25 ml per hour. There was chest X-ray right basal zone haziness maintained, but
at this stage, can I stop you?
Yes.
Based on your findings, there is worsening shock, right? Worsening acidosis. Are you happy with your resuscitation? Do you think the preload is adequate? And is there a chance that the preload may not be adequate? And if you want to look for the adequacy of the preload at this stage, what more can you do to find out whether the patient is still volume responsive? I qualify volume responsive. Now you have intubated and ventilated him.
Ma'am, after intubation and ventilation, we can see the dynamic parameters.
You already have an art line in C2,
yes.
Right? Yeah. So what will you look for?
Ma'am, we can look for pulse pressure variation in the monitor.
Right.
We have.
And what will indicate a volume responsiveness here?
Ma'am, greater than 13% or.
Yeah, okay, sure.
Ma'am, then the lab values on the day 3 also, there was increased in creatinine and BAN. There is increased in TLC on day 3 of admission. There is increased INR to 5.6 and the bilirubin also rises to 24.6. As we are already on the day 3, the hepatology team along with the gastromedicine along with the gastrosurgery team, we started working up on the transplant and discussion with the family started.
Just
The
just
repeat-
hold on there. Just hold on to there. Now you have somebody in a grade 3 to 4 encephalopathy because of acute liver failure. So and your CT is already showing cerebral edema, right? So what will be for the cerebral edema, what targets will you give your nursing staff to manage the cerebral edema appropriately and not to let it worsen? What will be your targets?
So, ma'am, first of all, in this case, what we have done, we have shifted the patient to an isolated, dark, with low light room.
Oh, let's be very clear.
No,
You have
doctor,
insulated and ventilated.
Doctor, the question was very specific. Okay. What are the targets that you are going to tell your nurses? So don't go off tangent and dig yourself into greater trouble by bringing things. I shifted the patient. Very specific question, because you will actually irritate the examiner. See, you understand that we have 20 minutes to assess you. I mean, this is a different scenario because we are actually discussing over time. But in 20 minutes, if you start waylaying the examiner here, there, everywhere, you are going to lose unnecessary time. So question was very specific. What are the targets of monitoring you are going to give your nurse?
For raised
Let us-
ICP. For raised
Sir,
ICP.
Sir, ma'am, the map should be around 75 to 80 in this patient. And second, ma'am, ETCO2 monitored, if attached, is between 35 to 38. The patient should be normothermic and
So just a small qualifying of that statement. ETCO2 may not be necessarily 35 to 39. It is the PCO2 which may be 35 to 39. So ECO2 may have a lag of 5. So it's very important that you say that the ABGCO2 or PCO2, I'd like to keep between 35 and 39. And according to that, you see what is the difference or the gradient across to say that the ETCO2 and judge by that. So it's not the ETCO2, but it's the PCO2. Okay. Yeah.
And
Go
most
on.
important,
a sodium level is greater than 150.
150? Would you want to give it a thought again? Would you want to give a limit of above 150? So you would want it 160?
Ma'am, up to 155.
No, give a range.
Range.
Ma'am,
So it can be 125 to 155?
Ma'am, 150 to 155.
No, is that the recommendation for raised ICP management today in the 2023?
– 145 to 1.
So it's around 145. Yes, you don't. 150 used to be way back. Now it is 145. That would be ideal to keep the sodium around 145. On the higher side of 145 is okay. Now your patient sodium is 138. How will you meet this target?
Ma'am, we can use hypertonic saline boluses of hypertonic saline. In our institution, we use 3% normal saline, 250 ml bolus over 30 minutes.
3% saline, don't say normal saline. 3% is not normal saline, 3% saline.
Saline, yes.
250 ml bolus, is it?
Yes. 2 ml. But,
Sorry?
250 ml.
Okay.
Mm.
So that is used regularly or as a rescue measure in case 250 ml is a big dose. So is it used as a rescue measure when you have a papillary inequality? Because here we just want the sodium between 140 to 145. So it would be wiser to start an infusion and keep monitoring the sodium every 6 to 8 hourly so that you remain within the range of 140 to 145. That bolus is given as a rescue measure when there is a threat of coning. Right? This is maintaining a sodium between 140 and 145. The target is different here. Aim is different. Okay. You have mentioned ONSD here, doctor.
Yes, ma'am.
Right? So it was 6 and 6.2.
Yes,
So is this normal Is this raised? What does it tell you?
Ma'am, over 5.8, the specificity of ONSD correlates with the increased ICP. So this is, in this case, it is raised.
Okay, yes, sure. Any other way of monitoring raised ICP? So ONSD can have an inter-observer variation as well as an intra-observer variation. Any other way of monitoring ICP that you know in liver failure? You may not have used it here, but any other modalities, non-invasive, invasive, both?
Ma'am, in non-invasive, we can use pupillometry or neurological pupil index. We don't have the facility there.
Yeah, it's any other modality?
I mean, non-invasive.
Yes. Have you heard of MCA Doppler?
Yes, sir. TCD, matlab transcranial Doppler, we can measure.
Yes, so you can do a TCD and measure what is called as a pulsatility index. And that will be more objective and less variation between inter-observer variation, right? Any other invasive ones that you know?
Ma'am, in the intraventricular catheter or the parenchymal catheter or subdural bolts.
Yeah, okay. Which will be a bit difficult in this case, considering the coagulopathy. Though
Yes.
it is done, but yes, it will be difficult. Any other invasive modality for monitoring this person's ICP? Invasive again, I'm asking. Have you heard of reverse jugular lines? No? Okay. SJVO2, monitoring the reverse jugular saturations, right?
Oh,
so you could monitor SJVO2 also, and that also would. So if I tell you that this person's SJVO2 is say 88%, I put in a catheter and I took the SJVO2 and it is 88%. What does it tell you? It's similar to SCVO2. You understand that? Very high SJVO2. What will it tell you?
Either there is increased amount of oxygenation done in the blood, or there is less extraction due to the hyperdynamic circulation.
No, less extraction due to what?
Raised ICP or
exactly, raised ICP. So there could be that the
confused
ICP
with
is so high that there is no extraction happening, and that's why the SJVO2 is so high, 88%. So very low is also telling you something is wrong, and very high is also telling you that. So don't be happy that it's 88%. That's what I'm trying to make a point. Low is obvious, but high is also means that maybe the intracerebral circulation has stopped because the ICP has become so high. There is no extraction happening. Okay.
So can I go next slide? On the day 4 and 5, the GCS was E2, VT, and M4 of sedation when examined.
So can I interrupt you here again? Since you have called in the transplant team, do you know what are the criteria used as an indication for transplant in acute liver failure? What criteria are used?
Ma'am, King's College criteria,
Clichy
criteria.
Clichy criteria. So can you apply Clichy criteria in your institute?
No, ma'am, factor 5.
Yeah, okay. Now this King's College criteria, there are two criteria, right? Two subsets of it. Are you aware that there are two subsets? One for paracetamol, one for non-paracetamol etiology?
One for non-paracetamol and one for non-paracetamol.
Non-paracetamol, right? Now, you will apply which criteria here?
Non-paracetamol.
Yeah, obviously non-paracetamol. Okay. Now, just one word here. King's College criteria were not meant for acute hepatitis A and E virus, okay, because they don't have that etiology there. So yes, your answer is absolutely correct, King's College criteria, but there has to be a qualification to it, is that the original criteria when they were derived, there was no patients of acute Hep A and Hep E because they don't have that there. So basically they're not the ideal criteria, but yes, in India, all over India, still KCC is used and the sensitivity specificity is still very decent, even for hepatitis A and E. I could ask you the
In fact,
sensitivity specificity, but that's a very detailed question. So as long as you're aware of King's College criteria, that's good. What
in
is
fact,
the
if you look at the King's College, one of them is that non-A/non-B is what
Non-
is taken as one of
that
the
is
criteria.
seronegative
Mm.
hepatitis, yes, but that
Right.
still is not the A or E. It's a seronegative hepatitis. So does your patient fulfill King's College criteria, doctor? May I ask you?
No, sir, ma'am. Actually, at that time, the INR is still 5.6. Is not gone above 6.5. And in the below category also, it fulfill two criteria. One is, ma'am, bilirubin is 17.4.
Yeah.
Bilirubin is above 17.4.
And INR is 5.6.
5.6.
So 3 out of 5 have to be fulfilled, right?
Yes.
In the second box.
Yes.
Okay.
Then, sir, the patient gradually become anuric. In the labs, the TLC increased on the subsequent days. Also, we have escalated the antibiotic and the antifungals were added. The increased INR, the INR goes on increasing and the bilirubin also increased. There was also increase of BUN and creatinine. As on the day 3, there was also increased ammonia. So we initiated CRT and it continued for the next 3 days. And
What mode on CRRT?
In this case, we started with CBV HDF, but initially the ultrafiltrate was removed on the day 1 and 2, but then in day 3, their ultrafiltrate was not removed during that. But we initiated because once we started, we cannot shift to downshift to HDF. So we have started in the 3 days in the CBV HDF.
So
How much of HF, how much of H did they use?
dose, what was the dose?
Dose is 25 to 30 ml per kg per hour.
Did you use any anticoagulation on it?
No, ma'am. In our case, we didn't use anticoagulation.
So how do you maintain the circuit patency when you don't use any anticoagulation?
Saline flush.
Okay. Yeah. Okay.
And we also planned for the plasma exchange, but the relative were not keen at that time, and by that time the patient was taken for transplant, so we couldn't do that. The culture which we sent on the day 3 was sterile up to 24 hours as per our microbiology department. Next. And sir, in the subsequent time, the day 6 to on the day 6 of admission, the transplantation, live donor liver transplant was done. The post-op event was, it was uneventful. We extubated the patient on day 3. It will be POD 3, sir, because of delayed GCS, maybe mostly because of the cerebral edema. The antibiotics were continued as per our transplant protocol, and the post-op, all the measures were done. After extubation, we added up to immunosuppressant, anticoagulant, heparin infusion, mobilization, and the investigations. And on the day 10 of transplant, the patient was discharged.
Okay, Sunil, you have any questions on this?
No, I think.
I think, yeah.
You have exceeded the time also, I think. Yeah.
Yes, exactly. Yes, we have exceeded the time. Yes.
Mm.
It's okay, ma'am.
uh,
Yeah, you can go on.
yeah, so I think from the exam standpoint, if you reach up to the transplant part, I think you're through. You have done pretty well, I would say. So they may not be sort of harping on things beyond that. What is the immunosuppression? How much? All that is a little beyond a normal critical care sort of curriculum. But anyway, it's good to know about these drugs. At least for the theory, I think immunosuppression, classification of the drugs, it's important. And also need to know importantly, you need to know what is the complications of these medications. Okay, of course, commonly it's going to be TAC methylpred. So you just have to be aware of what is the complications of this, and perhaps when they may choose to use cyclosporine instead of TAC, which is rare, but they do use it in certain specific scenarios. So just read up about those things. Okay.
Can you answer if what volume of plasma exchange would you use on this patient? How do you? Okay, so
Plasma volume will be decided based on the total blood volume multiplied with my total blood volume and from the hematocrit. So it will be total blood volume multiplied by
in this acute liver failure, what recommendation? Now is the
there is a formula.
it's a high.
So there's a formula for calculating the plasma volume.
Calculating the plasma
you
volume.
calculate the one plasma volume for the patient. Now, would you use a one plasma volume exchange?
High plasma volume plasmapheresis, three times at least, 8 to 10 liter of plasma exchange we should do in case of acute liver failure.
Yeah, so that is the Larsen trial, which showed that high volume plasma exchange is what is recommended for acute liver failure, and it has shown to have a better transplant-free survival.
Yes.
In real life, in practice, in your institute, do you actually use high volume plasma exchange?
Ma'am,
that was a trial situation, okay? In real life, in your institution, what is the protocol, if you know?
What is the protocol? What is the common practice in our country? Let us put it that way.
The world over also. That was just a trial. World over.
1 to 1.5 times plasma volume.
1 to 1.5, single volume to 1.5. How many sessions would you give?
3
to 5 sessions.
What is the downside of plasma exchange? Sorry, I'm exceeding time here. This is my last question. What is the downside of plasma exchange? As an intensivist, what will you be worried? What will plasma exchange cause?
Adverse effects.
Volume overload.
Yeah, one. Yeah, then
decrease in the platelet count.
Okay, thrombocytopenia. So you mentioned TACO, you mentioned thrombocytopenia. What else?
Catheter-related complications.
Okay, fine. Let's just talk about plasma exchange.
Plasma exchange. What are the problems?
Anaphylaxis also it can cause.
Hypomagnesemia. Dyselectrolytemias.
Hypocalcemia. Okay. You mentioned TACO. Anything after TACO? What is TACO I'm talking about?
Transfusion associated
cardiac
overload.
Circulatory overload. So you are actually, that's smart thinking. I think you just guessed it, but that's smart thinking. So after TACO, what is that? What else happens?
What happened? Similar presentation, but delayed.
What we are always worried about when you use such high volume plasma, it's trolley. So you can have trolley, you can have TACO, you can have thrombocytopenia. And what else happens? Your antibiotic levels go down because you're removing 1 to 1.5 volumes of plasma. And when you remove that, your antibiotics become subtherapeutic. Antifungals become subtherapeutic. So you're always worried about sepsis. You need to bolus those antibiotics extra dose after every session of plasma exchange.
That is also one of the reasons why the high volume is not preferred over normal volume. Because if these people are going to go for transplant, then you'll be further suppressing them. That's why most people pragmatically look at 1 to 1.5. Okay.
Practically, how do you do the plasma exchange? What are the two methods?
The one
And one centrifugal based and one membrane based, based on the coefficient of the membrane, and one based on centrifugation technique.
Which one do you use in your institute?
membrane based with the CRT machine.
Okay. 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 That's what I think they've done very well here.
And
Any further?
just about the neuroprotective measures, be aware. I mean, there are 4 or 5 things which you have to, I think I missed that part. Sorry, I had to go for a call at time. So just be, having your, what is called as neuroprotective measures, which we discussed, be thorough about it, because there was a little bit of fumbling when we came to that.
And the first thing should come is head up. Okay. I mean, you gave the other targets, but for the nursing, it's head up is the first thing. And then sedation analgesia should be adequate. So going back, what sedation analgesia would you use for the neuroprotection here? This is acute liver failure.
We use fentanyl and propofol, but we should not use fentanyl. We use fentanyl and propofol.
Okay, so there again, I'm saying, don't dig a grave for yourself.
Yeah.
So you're using propofol and fentanyl, good enough. What will be the ideal drug that you would want to use?
Remifentanil.
Okay, yeah. And if it is not controlled on just propofol, how high a dose of propofol will you use? Weight-based. How high will you go? And what is the risk of going higher?
Propofol infusion syndrome.
Yeah, okay, right. So what dose will you use? You must know that. Okay, you are intensive care, right? You must know your sedation, analgesia, paralysis like the back of your hand.
These are the common drugs that you use.
Absolutely, this is our drugs. We must know the ceiling drug or dose of every drug. So on propofol and fentanyl, you still find that the patient is having hypertension and bradycardia, which suggests raised ICP. What will be the next option for you?
Neuromuscular blockade.
Here also, this is beyond time, but you would want to do a EEG to see if the patient has non-convulsive status epilepticus, and because that's one of the reasons why the ICP is not coming under control despite adequate doses of propofol and fentanyl. And yes, you would start a neuromuscular paralysis, monitor it with your TOF monitor, but you would want to do a EEG to see if there is NCSC and if any anti-epileptics are indicated. Okay. Okay.
There is one question, ma'am. Yeah, basically, Sunil sir, what is the difference between transaminitis and hepatitis?
You want to take that, Dr. Prithvi?
In transaminitis, the liver enzymes are
Number of times from baseline is how much for transaminitis, is how much for hepatitis.
up to 20 times is
3 and 5. Right, no, Dr. Vaishali?
Yeah.
3 is transaminitis, 5, more than 5 becomes hepatitis. Okay.
But it is used interchangeably also. It is used in real practice. It's used interchangeably also.
Okay.
Yes, sir. Yeah. So basically, there is one other question, which is like, what are the tests which show that alcohol consumption present other than GGT?
So in this particular patient?
Yeah, I think maybe in general, probably.
Yeah, exactly. Because he's come to you encephalopathic, and for 7 days, he's probably not had any alcohol. So any other test is not going to tell you.
I think it's not of any practical value.
Yeah.
That's the first thing. And GGT can actually even go up in any situation where there is developing hepatitis. So it's not necessarily that it should be only in alcohol, but it can tend to go up.
Yeah.
So in this patient, it is impossible to, at that point of time, because he's come after 7 days of symptoms, and his enzymes are already in the hepatitic range, so you won't be able to make out.
Correct. So I think any further things that you want to add? Yeah, final comments.
No, nothing, I think.
So
Yeah,
Sunil
just
sir.
be careful with the words. I think, it's very important that you don't be splurging around words like which are sort of, very vague and very this thing. You need to have very clear-cut definitions for each one. You have, whatever the definition, you could give a reference to say that this is my reference for this definition, that is fine. So as I already said, just divide your presentation into a brief, don't have to give a very detailed complaint list. You can just say such and such year-old gentleman, acute febrile illness with jaundice of 1 week, fever. So just very, very brief. Positive salient features in the history, because you have only 20 minutes. So in that 20 minutes, you should spend 5 to 7 minutes for presentation. Then the rest of the time will be examination, because if you have a long stay patient, it will be presentation in the other hospital. You may have to divide it that way. The complaint, how he presented to the previous hospital, what is the presentation in the ER, course in your ICU, course in the hospital, and then come to the current day's finding. So that kind of demarcation you have in your own mind, so that it makes a very organized presentation. Because as I told, we are not trying to make you MD physicians here or MD anesthesians. You're actually becoming a super specialist here of a critical care nature. So it has to be focused towards critical care. Okay. Right.
Vaishali madam, any final comments from you?
Oh, I think they did pretty well. Just don't contradict yourself within normal limits. Cerebral edema, no evidence, but we do this. Don't contradict yourself. If you don't know the evidence, just say our hospital protocol is that we use an N-acetylcysteine, because you're contradicting yourself.
Yeah. And I think it's important that you read that meta-analysis which Dr. Vaishali told you. It's a very useful one about, and significant sort of benefit has been showed if you look at the forest plots and the
non-paracetamol,
Yeah.
Also.
Okay.
Okay.
Good.
Okay.
Okay, ma'am. Yeah, I think with this we come to the conclusion. I thank you very much, Dr. Vaishali ma'am and Sunil Karanth sir, for your definitely a very elaborate discussion on acute liver failure, which is very much beneficial across to all students. And thank you for giving your valuable insights and inputs into how to prepare and how to definitely deliver during exams and all. And thank you, Dr. Prithvi and Dr. Arnab, for bringing out this case, because of which we could have a good discussion. So, and I thank my Yashoda Hospitals and our digital team for providing a platform to have these classes regularly. So, and Hyderabad IDCCM chapter for regular coordination and having these sessions more and more. Thank you very much. Good night.
Thank you.
Thank you. Good night. See you later. Bye.
Good night, Sunil sir and Vaishali.
Good night. Good night.